For the next one, for the next talk, we're going to stay in the knee, but we're not going to go for the ligaments. We're going to go for the cartilage instead. We're also going to stay in Northern Europe. You know that the previous speaker has done a lot of his research in Norway. We're just going to move over the border to Sweden. I'm very happy to introduce Mats Brittberg, who has been a visiting surgeon at Aspetar for some time, and his specialty is the cartilage repair. And so, Mats, please come on the stage. For the biography, I invite you to look in your little booklet that you have. You know, all the details about Mats are there. So the floor is yours.
Thank you. Thank you very much for the introduction, and thank you also for inviting me here to give me the opportunity to talk to you a little about cartilage repair in handball players, what different types of techniques and what you could think about. If you look about a handball match, you will see that most of the players have had some sort of injuries. And if you look upon it, several joints can be injured during handball playing because it's a physical contact sport, and you have the knee joint, you have the ankle joint, but also joints like the wrist, thumb, elbow, shoulder, and hip. If you look upon the frequencies, you could see on this slide where you have the different areas that could be injured, and especially the joints. And this paper by Rosa and co-workers, they looked upon the most frequent injury, as we've heard earlier today, the ACL injury, and you could see especially in handball, and especially in women's handball, that you have the injury. There was this paper, because if you look upon handball and cartilage injuries, there is very, very little written about cartilage. But you could see the consequences of the cartilage injuries. And they looked upon 24 female national team handball players involved in the Olympic Games in Sydney in 2000. And they looked upon them from start, and then at 10 years later, and they started to look upon with x-rays, and then follow up with a questionnaire and also x-rays. And the mean age at the assessment was 26 years, and 75% of them fulfilled criteria for radiographic OA. And 75% reported also having severe symptoms affecting their knee-related quality of life. And more than 50% of the players had undergone reconstructive surgery or debridement in the study period. So you could see the consequences 10 years after finishing their handball playing. Lermet and co-workers, they found also a close relationship between long-term elite handball practice and the incidence of hip OA. So 60% of the handball players were diagnosing with OA in at least one hip joints, compared to the normal population with 13%. So also here we should know the consequences after stopping playing handball. And the risk of developing premature OA seems certainly very high, but there's a speculation that there could be also not violent large trauma, but also micro trauma that by time induce an osteoarthritic development by the degeneration of the labrum and the cartilage lesion following a labrum injury. So then we are looking on a player, an athlete, could be the handball player. We should look upon the recreational and the professional, because the recreational player have a demand of relief of pain, return of functionality, and some sport participation. But the professional player is more difficult because they need a very fast return to the previous high demanding activity. And that could be more difficult to know how to handle those patients because there are problems with different types of repair technologies that we will look upon. Repetitive exposure of articular cartilage can by time develop less possibility of the cartilage to recover after injury, and by time you develop cartilage injuries. I mean, if you look upon athletes, there is a high prevalence of focal cartilage lesions seen, around 35%. But if you look upon the normal population, you have 5 to 11%. And also, if you look upon the literature, you have to go through a lot of papers. And finally, when we looked upon soccer players, we found only 14 relevant articles that could be related to the injuries of local cartilage lesions. And then we looked upon the different types of treatments that were available. And microfracturing, certainly one of the most used techniques for cartilage repair, showed a statistically significant improvement from baseline in functional outcome, pain scores, and tender activity levels after 1 year after surgery in professional soccer players and also other athletes, so you can compare it with handball players. If you looked upon chondrocyte implantation technique, you also had an improvement from baseline in function and even little better results if you compare with microfracturing. And also, if you looked upon the activity level with tender activity scores, that were significantly higher after ICI in soccer players. We could also look upon osteochondral autograft technique, different types of mosaic plastic techniques, and also resulted in good results up till 17 years follow-up in a mixed athletic population. But then if you look upon the different type of technique, because we should know that with cartilage repair, it's a very, very slow repair process. The maturation time is very long, and you have to have a lot of patience, both the doctor as well as the patient. And if you look upon ICI, the recovery time is very long, 18 months in meantime. By microfracturing and osteochondral graft are quite shorter, less than 1 year, you see 8, respectively 7 months. So for the professional athletes, the longest follow-up with good clinical outcome after ICI and microfracturing being 5 years, and with osteochondral graft up till 8 years. But still, there is not enough knowledge with different types of athletes and very little about handball playing. So that is, we need you all to start doing research also with cartilage lesions. When we are looking to treat the cartilage lesion, we look upon the size of the lesion and we look at the involvement of the subchondral bone. And we could turn up with an algorithm for normal patients like this. We will later see that there is a little different algorithm when we are going to treat patients with sports injuries because of the demands. Frequently also the articular cartilage lesions are accompanied with other lesions, and most often it's ACL ruptures, around 16 to 40% in the material with concomitant cartilage lesions. An increase in treatment delay up to 3 years after an ACL injury lead to a higher incidence of articular cartilage lesion. So it's important for an early detection and direct treatment of ACL lesions athletes in order to prevent the development of cartilage lesions. Amin and co-workers also showed that the combined treatment of articular cartilage lesion and ACL rupture resulted in a better clinical improvement compared to cartilage repair with ICL following previous ACL reconstruction. So you have to consider that you may have to do treatment of both injuries at the same time. Although ICI and NOTE seems to lead to a better structural repair and are more likely to result in a total resumption of previous activity, it's not the treatment of choice most often among the professional athletes. Because also the long rehabilitation time after ICL, microfracturing had been considered the first treatment of choice among athletes. And from the athlete's point of view, microfracturing is a reasonable choice, and it's safe, and it's a simple technique that most doctors could handle, and allows the career to continue for at least a couple of years. But given the shorter average rehabilitation time after osteochondral graft compared to microfracture and ICI, this technique could also be a good offer, because then you directly get a very stable repair tissue compared to microfracturing and ICI, where you have to depend more on the maturation time, even though in osteochondral grafting you have to wait until you have bony repair. If ICI is the treatment of choice, a surgical debridement of the acute symptomatic focal lesion could be the first choice. You notice the lesion, you think this patient would need an ICI, but it's a problem with the sport, so you do a debridement, You harvest cartilage, send the cartilage to the lab. The lab put the cartilage in the freezer, and the patient could be rehabilitated faster. And when after season, the athlete could go back to the surgery and have the ICI performed. So with this in mind, the better structural repair of you could consider to use ICI nodes. So for focal lesions larger than 2 square centimeter, microfracturing nodes have significantly worse results compared with ICI. So those type of treatments are more preferable for lesions less than 2 square centimeters. For ICI, there is no influence on lesion size, and clinical outcome or return to sport participation has been found better, and that indicates for the larger lesion, ICI is the treatment of first choice for professional and recreation sport athletes. And for the professional football player and other high athletes with symptoms less than 12 months, Mithofer and co-workers found that you have greater return to sports. And also when treated with osteochondral graft, the chronicity of the lesion seems important and on the clinical outcome and return to sports. So even here, you have to detect early and you have to treat them early in order to less involvement of the surrounding cartilage and develop into a larger lesion and chronicity. And then you turn up with a little different algorithm where you could also see how you could handle the patient depending on the size of the lesion, but also if it's beginning of the career or if it's end of the career, you have different options to choose. So back to microfracturing, that is certainly the treatment of joints for the smaller lesions. But recently we have learned that you could do different when doing bone marrow stimulation technique. Bushman and co-workers in Montreal, Canada have shown that if you did shallow drilling and microfracturing and compared it with deep drilling, as you could see on this picture here, you had much better results with deep drilling. So then industry have been quite fast to adopt these ideas. So today, instead of doing microfracturing with small puncturing lesions in the bone marrow, we go deeper down into the bone marrow with needle drilling like this, nano deep drilling, or with flexible drilling down to 7 to 9 millimeters depth compared to when you do microfracturing around 3 to 4 millimeters. Also talking about ICI, all what I've been presented regarding ICI has been with open surgery. And today most of the ICI could be done transarthroscopically. Myself, I could do 95% of my patients transarthroscopically. And here you could see a trochlear lesion, and here is implanted transarthroscopically with cells in hyaluronic acid scaffold. So then you have much faster rehabilitation. So the future treatment alternatives are for small defects, synthetic osteochondral graft, thermogeles for fast blood clot stabilization, and matrix support bone marrow stimulations with or without growth factor stimulation and PRP. For large defects, you are using cell-seeded implants, either with chondrocytes or allogenic stem cells. Direct isolation is also possible with chondrocytes together with mesenchymal stem cells. Also, technologies with fragment cartilage could be autologous or allograft, and also osteochondral allografts. Looking a little about the joints. The knee joints certainly are the most common location. And Mickelbust and co-workers showed that 22% of non-operatively treated players returning to sport underwent additional surgery for an injured meniscus compared with only 12%. So returning to this sport without a reconstruction resulted in risk of injury to the menisci and cartilage. So again, you should think about the combined treatment. And Renström and this group, they looked upon team handball players, and they found the incidence of ACL injury was highest in women playing at top level compared to to the other group, as you can see here. And the highest incidence of ACL injuries occurred in female elite handball players in Norway. But even though they have a lot of injuries, they succeeded to win the gold medal at the Women Championship earlier last year. Olsen and Myklebust also reported on the risk of having an ACL injury regarding the quality of the floor. And I think this is also what we should think about when we are thinking about cartilage injuries, because cartilage injury is very seldom and single entity. It's in combination with other injuries like the ACL injuries. So it's prevention. And that's, I think you have already talked about earlier yesterday, but we will talk more about it, prevention. And we've heard from the speaker, Koga, that how the ACL is injured with a heel touch near full extension in a landing or deceleration, and in female players often a forceful valgus collapse with the knee near full extension combined with the tibial external rotation. And that means that we have these very side cutting movements, and cartilage is injuries with rotation and shearing forces where the cartilage layers are shed off. And at the same time that you have the ACL injury, we also have this lateral compression and the involvement of the cartilage injuries. And then you have to think about also when we are going to treat the patients for ACL injuries. The most often used graft today is the hamstrings graft, but regarding the increased activity of medial hamstrings to match the external outward rotating knee movements, that could be a negative choice, and we have to think about that when we are also going to prevent our cartilage injuries. From the Scandinavian ACL registry, it has been noticed that male handball players had greater risk for concomitant cartilage injuries after ACL reconstruction compared to male soccer players. A new sport among women that significantly increased that risk for cartilage injuries. You have also differences between the women and men in handball play regarding the evolution of cartilage injuries. The elbow, we have this paper by Nebojsa Popovic and Lemaire about the hyperextension trauma. And also here we could see, and I have had patients coming after this type of injuries also having severe cartilage injuries. You have the shoulder, focal chondral defects of the shoulder are relatively rarely reported in young and active patients. But you have also articular cartilage surface injuries here due to high impact forces, repetitive shear and torsional loads. And chondral defects could also develop by progressive cartilage damage from repetitive mechanical irritation. And here you have the possibility also to do ICI, as this picture shows. There are very few reports on ICI in the shoulder. I've only done one myself. Here's a report on 3 patients. As you could see here, but I think that will be possible more and more now when we could do it transarthroscopically. The hip, cartilage lesions in the hip joint are a bit different from other lesions, mainly because the majority of the lesions in the hip are secondary to a labral damage and could be detected and treated early with repair of the labrum. Then you will have less cartilage damage. But they could be treated the same as in other joints, but different compared to other joints is that you could also here repair a flap, fixate it with a glue and put it in place, which is very seldom that you could have success in other joints, maybe because of the hip joint being more protected. And here also an alternative that you could do transarthroscopically. Here's a bone marrow stimulation augmented with chitosan enforced blood clot stimulation, and the technique is quite nicely to perform. So finally, the presented findings and research regarding handball players is that prevention prevention is very important. So player must be aware of early osteoarthritis and functional limitation of the lower limb of the knee and ankle reconstructions in the early period of team handball. Because as we saw from my first slides, so many players are developing osteoarthritic joints, the knee joint and the hip joint. And if you think that they are finishing at around 35 and they will develop hip OA and knee OA already at between 40 and 50 years of age, we have a problem. So prevention is very important in order to reduce the number of patients in the future. Because here is from my colleague at my hospital. He's team doctor of the female, Swedish female national team in handball. And in 4 minutes, all these 3 girls were injured. So more research on how to prevent and minimize the number of injuries, and also by that reduce the number of cartilage lesions, is very important in the future. I thank you very much for your score and attention.
Thank you. That was a very comprehensive review. Thank you very much. Just one thing I'd like to add, and that is to make sure you check the weight-bearing line on these people by doing standing long leg films. And if the lesion is going right through the weight-bearing line or on the wrong side of it, then you have to do some sort of unloading osteotomy, or you will have a lot more chance of failure. Would you agree with that?
Absolutely, and osteotomy is one of my favorite operations. So
Other questions? Look around, last chance. Oh, Philippe, yes?
Thank you much for, we are used to hear your fantastic presentation always, but can you, you know, in terms of return to sport or return first to a normal activity, we know it can be delayed based on the importance of the cartilage lesion. In the case of this type of sport, so handball, which is high demanding, let's say if we talk about knee lesion, do you have some algorithm or protocol guidelines to prolong return to sport, delay to return to sport, depending on the depth of the lesion and the surface of the lesion? Or do we have some evidence about that?
well, you know, the lesions that we are treating are the deep lesions that are more than 50% of the depth of cartilage. The superficial lesions are more difficult to know about. Then I think bone marrow edema is something that you could use to follow. And if you do an MRI and you see a bone marrow edema and there is a partial thickness lesion, the player should be careful and you should follow that. But still we don't know so much about the bone marrow edema because it could have different causes. But if there's a bone marrow edema, you should pay attention and the player should be reducing the activity. But you could always, it's also the symptoms that certainly govern the activity of the patients. But it's demanding if you have a high quality athlete. People want that person to go back very much to sport. For example, there is the Swedish handball player Kim Andersson with a shoulder injury. Everybody wants him to play tonight, and they were going to give him acupuncture treatment, I was reading in the journal. But certainly pain is the body's information that you should be a little careful. And it could be that you will have more injuries, and if you go back with some sort of painkillers, you will have development of more lesions, and by that osteoarthritic lesions in the final end. So it's a balance that is difficult to know about, but that is for everyone to do further research on.
Thanks, Mats. I think we're going to move to the next talk.